Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode features coverage of COVID-19 data from the virtual IDWeek 2020 conference. During this episode, Dr. Rajesh Gandhi from Boston, Massachusetts, will discuss important new COVID-19 data presented at the conference, including new findings on transmission in different settings, symptom progression and clinical outcomes, detection of non-SARS-CoV-2 viruses during the pandemic, and treatment and prevention strategies. For more information on Dr. Gandhi and for a link to additional online CCO coverage of IDWeek 2020, including a downloadable slide set covering the studies discussed in this episode, please visit the show notes. Now let's get started and hear what Dr. Gandhi has to say about these new data.
Welcome, everyone. It's a real pleasure to be here today. I'm going to be talking about recent highlights from IDWeek. And I'm going to cover these topics in several different categories. We're going to start off by talking about transmission in various settings. So we'll then talk about some studies that give us information about symptom progression and clinical outcomes. We'll then talk about detection of non-SARS-CoV-2 viruses during the COVID-19 pandemic. And then we'll finish off with a discussion of some important studies related to treatment and prevention. And then we'll open it up for question and answer and discussion. So let's go ahead and get started. And we'll start again with transmission in various settings. So the first study I'd like to present is a study from Nashville, Tennessee. And the background to this particular study is we know that household transmission of SARS-CoV-2 can occur, but many of the studies that have been done to date have been done overseas. And they've given a really broad range of rates of transmission within households, ranging from as low as 4% to as high as 40%. So what these investigators wanted to do is to really try to nail down what is the rate of transmission within a household when a person with COVID-19 is newly diagnosed. And so the way they did this is they did an ongoing case ascertained study. It started in April in Nashville, Tennessee. And in this particular study, the index cases were ambulatory patients who had had a positive RT-PCR. So people were eligible for this study if they were the first person within a household where the household had two or more individuals, and if they were the first person who was presenting with new onset of respiratory or other symptoms compatible with COVID-19. So what the investigators then did is they measured new infections among those at risk over the ensuing 14 days, and that gave them what they call a 14-day secondary infection rate. They enrolled a total of 60 index cases, and they followed 101 household members in the households of these index cases. So here are their results. The first result I want to stress is that the overall rate of secondary infection within a household was 50%. So a rather high rate of household transmission of 50%. When they then looked at the characteristics of the index case, one of the questions, of course, out in the field is, do children transmit COVID-19? And so when the index case was less than 18 years of age, the secondary infection rate within the household was 32%. So this really shows that children can transmit COVID-19 within a household. Now, one of the aspects of this study that I would be interested in is what is the age range below age 18? We think that young children are less likely to transmit COVID-19 than teenagers, but this is an area that we definitely need more information on. When they then looked at if the index case was Hispanic, and they then calculated the secondary infection rate, the secondary infection rate was 73%. So really a very high secondary infection rate in households where the index case was Hispanic. The investigators went on to do a sensitivity analysis. This is important because even though they were doing testing of the individuals within the household, it's possible that even though the index case was the first to be recognized, that a person entering the study within the household may have been infected at the time of enrollment. So what they did is an analysis where they took out people who were infected at the time of enrollment, and then they recalculated their secondary infection rate. And at that point, they got a secondary infection rate of 33%, so still a rather high secondary infection rate. So the authors concluded that living in the same household may increase the risk of infection. It certainly seems to be the case, but it is possible that some infections may have originated outside the household, and they're continuing to do viral sequencing to try to nail that down and to be sure where these infections originated. So what are the take-homes from this particular study? I think it shows us that there's a high rate of transmission within households, and that this really reaffirms for us that we want to counsel our patients around some of the isolation procedures. The CDC has a nice list of isolation procedures when an infected member is within a household, and these include things like, insofar as it is possible, to have the infected person in a separate bedroom and to use a separate bathroom. I understand that's not always possible, but if it is, that's thought to be helpful. To maintain as much distance as one can within the household, again, not always possible. And then to potentially have the infected person eat separately from people who are not yet known to be infected. So a really important study on a really important topic. So now let's go on to a second study, and this is a study that tracked COVID-19 in healthcare workers. And this is setting up an active surveillance program within a healthcare setting. So these investigators established a prospective cohort study of healthcare workers that are affiliated with Yale New Haven Hospital. And all of these healthcare workers had a potential for occupational exposure to COVID-19 by virtue of the fact that they worked in an emergency department, or they may have worked in an inpatient unit caring for people with COVID-19. So these investigators enrolled a little over 530 individuals, healthcare workers. Most of them were under the age of 55. Only 11% were over the age of 55. Most of them were female. And the occupation, 62% of the healthcare workers were nurses, and 20% were physicians. The participants were then followed for the ensuing couple of months, 84 days, and they did a number of surveys. They looked at demographics. They looked at surveys asking for symptoms and exposures. And then, and this is important, they did self-administered nasopharyngeal swabs and saliva collections every 3 days to look for virologic evidence of acquiring COVID-19. And then they did blood sampling every 2 weeks to look for serologic evidence for acquiring COVID-19. 525 healthcare workers were followed as of June 1st, 2020. So what did they find? So in the red box, you see their bottom line results. The rate of virologic or serologic confirmed COVID-19 was 5.3%. So in this particular healthcare survey, 5.3% of individuals in this active surveillance program acquired COVID-19. Now, investigators were careful to say that they thought that most of these acquisitions were probably from community spread rather than nosocomial spread, although they can't know that for certain. The other main lesson from this particular study, and I think this is important, it's shown on the right-hand side of the slide, is when they looked at those people who had virologically confirmed COVID-19, 9 of the 16 people, the diagnosis occurred during the asymptomatic phase of infection. And so this suggests to the investigators that passive monitoring, symptom-based monitoring, may not be enough to prevent SARS-CoV-2 introduction in the healthcare setting. And this is a topic I'm happy to return to in the Q&A. So the last study I'll review on transmission comes from Brigham and Women's Hospital. And here the background, of course, is that throughout the early part of the pandemic, a lot of the public was concerned about going to a healthcare setting because they were concerned about acquiring COVID-19 within the healthcare setting, within the hospital. So what these investigators wanted to do is to look at the rate of nosocomially acquired COVID-19 acquired within the hospital. And they did this in 2 very interesting ways. First, they did an observational study of hospitalized patients who were PCR positive during the first 3 months of the pandemic at this large academic hospital in Boston. They enrolled all hospitalized patients who were diagnosed at day 3 or beyond of hospitalization, as well as outpatients who were first diagnosed within 14 days of discharge. And the reason they set up this classification is they reasoned if someone was diagnosed with COVID-19 within the first day or 2 of admission to the hospital, that those individuals probably acquired COVID-19 before they were hospitalized, and that's based on the incubation period of COVID-19. And similarly, on the other side, in people who were discharged, if they were diagnosed with COVID-19 within the first 14 days of discharge, they investigated those individuals as possible nosocomial cases. So they admitted over 9,000 people during those first 3 months of the pandemic. They performed somewhere over 7,300 PCR tests, and they confirmed a total of 697 COVID-19 cases. Then when they drilled down on people who were first diagnosed at day 3 or beyond, they found a total of 12 cases that they then investigated further. So here's a timeline of those cases. The cases of so-called late onset COVID-19, 3 days or beyond during the hospital, are shown in the orange bars. You can see a total of 12 such cases. And you can contrast that to the total number of cumulative hospitalized cases, which eventually reached close to 700. Also along the bottom of the slide, you'll see the institution of different infection control practices. Obviously, this was a rapidly evolving field throughout March, April, and May. You can see that, for example, universal masking of healthcare workers occurred in late March. You can see that visitor restrictions went into place in early April. Universal masking of patients and visitors also went into place in April. And then testing of all patients at the time of admission took place in late April, early May. So what were their results? So let's focus first on the 12 late onset cases. These were the people who were diagnosed with COVID-19 after being in the hospital for 3 or more days. When they did a close look at these 12 individuals, only one of those 12 individuals was confirmed to have acquired COVID-19 within the hospital. This was a man whose symptom onset was about hospital day 15. And when they looked into this further, he likely acquired COVID-19 from his wife, who had been visiting him daily until she became symptomatic. And this particular nosocomial acquisition from the visitor occurred prior to the hospital policies restricting visitors and requiring visitor masks. Now let's go to the post-discharge cases. There was 11 individuals who were diagnosed with COVID-19 within the 14 days of post-discharge. And when they did a deep dive into those 11 individuals, only one of those 11 was classified as likely hospital-acquired. So Dr. Chanuri, who presented these data, did give really kind of a postscript, though, which is a sobering postscript to this particular study, because so far the data suggests that nosocomial transmission of COVID-19 is really very unlikely, and it's a very reassuring message. But one postscript that he gave, which reminds us all that we continue to need to be vigilant, is in late September at the same hospital, there was a cluster of COVID-19 cases that affected staff and patients in 2 hospital units. And many of those cases seem to be tied to a patient who may have acquired COVID-19 during the stay. It's also possible that he had a false negative test at the time of admission. This particular patient had lung disease, was receiving nebulizers, which of course is an aerosol generating procedure, and had multiple roommates. So what this really reminds us is that we are going to continue to need to be vigilant for these type of clusters and really evolve our infection control best practices to make sure that we interrupt clusters as soon as we possibly can. And again, happy to return to this particular study in the Q&A. Okay, so now let's shift gears, and we're going to talk about symptom progression and clinical outcomes. And so a study I'd like to highlight here is looking at the really important question, which is there a difference in viral load, SARS-CoV-2 viral levels, between people who have symptoms and in people who do not have symptoms? And the reason why this is important is it may have important bearing on our thinking about transmission and our thinking about testing of people who are asymptomatic. So this particular study was couched in a large effort done by the Massachusetts Department of Public Health between April and June 2020. The Mass Department of Public Health performed statewide PCR testing of all staff and all residents in skilled nursing facilities and assisted living facilities. They ran over 32,000 nasopharyngeal swabs. About 2,900 PCR positive samples were identified. And so what the investigators did is they asked the simple but important question, was the cycle threshold levels of the PCR different in those people who did or did not have symptoms? So now what's a cycle threshold? Cycle threshold means how many PCR amplification cycles it takes in order to detect the SARS-CoV-2 virus. So the more cycles it takes, the lower the viral load. It takes more PCR cycles, and therefore the lower the virus levels. Now, in this particular study, 25% of people had symptoms and 75% did not, and this was a cross-sectional study. So what were the results? So what you can see here on the left-hand part of the graphic left-hand part of the slide, is that really the cycle threshold distribution was no different between the people who had no symptoms and the people who had symptoms at this cross-sectional look. And you can see that the cycle thresholds really ranged vastly. In fact, there was something like 100 million-fold range of virus levels based on these cycle thresholds. Over on the right-hand side of the graphic, again, you see really no relationship between the cycle threshold value, that is the virus levels, and symptom status. And that answers a really important question. One interesting tidbit that they shared with the audience is that 90% of the viral RNA was shed by only 8 to 9% of people. And this really reflects something we've known from epidemiologic studies, this idea of overdispersion, this idea that a subset of people, probably a relatively small subset of people, account for the vast majority of transmission cases of COVID-19. And that's something we've known from epidemiologic studies, but seem to be borne out by the virus levels. So what are the implications of this particular study? This study suggests that there may be a role of testing of people without symptoms, at least when the incidence is high in a community, to try to identify asymptomatic infections and to try to interrupt transmissions. In this particular study, they were doing it in a congregate setting, and that's, I think, a particularly important setting in which we need to be able to identify infections and then isolate people so that we can interrupt transmissions. So another feature of the clinical manifestations of COVID-19 is this recognition that COVID-19 has a spectrum. And the spectrum is both in terms of severity of disease, but also duration of disease. So these investigators from the CDC laid out what I think is a really interesting framework, ranging from acute infection, which is, of course, the majority of people with COVID-19, to what they call a post-acute hyperinflammatory illness, which is what we think accounts for entities such as MISC, the multisystem inflammatory syndrome in children, as well as the relatively recently described MISA, the multisystem inflammatory syndrome in adults. And then finally, more late sequelae that occur several weeks, if not months, after resolution of the acute infection. So we've all been seeing patients and hearing a discussion of lingering symptoms, persistent symptoms after resolution of COVID-19. So a study out of Emory delved into this further. So this particular study was done in a clinic called the Acute Respiratory Clinic. And what these investigators did is they did a retrospective chart review among patients with SARS-CoV-2 detected by PCR between April and May of 2020. And they classified their encounters into 3 different buckets. Acute encounters, which occurred within 7 days of the diagnosis. Subacute encounters, which occurred within 7 to 28 days of the diagnosis. And then what they call convalescent encounters, which occurred 28 days or more after the diagnosis of infection. And what they're trying to do here is to get a sense of the distribution of different types of symptoms as a function of how long after the infection people are being seen. So they studied a total of 107 unique individuals that visited their clinic anywhere from once to up to 4 times. 10 of these individuals had been previously hospitalized, but the vast majority of these people had been diagnosed and managed in the outpatient setting. So here are their results in terms of the symptoms during confirmed COVID-19 by stage of illness, by stage of encounter. And I zero in here on just a couple of key points. So if you look at something like fever, 60% of people who were being seen for an acute visit reported fever. But if you go over to the convalescent visits, fully 30% of people were still reporting fever at the time of a convalescent visit, which is really quite a concerning frequency. When you look at cough, 70% of people being seen for an acute visit had cough, but 66%, 2/3 of people still reported cough at the time of a convalescent encounter. When you look at dyspnea on exertion, in the convalescent encounters, 2/3 of people were still reporting dyspnea on exertion. And then when you look at something like altered taste or smell, about 1/4 of the people at their convalescent visit were reporting altered taste or smell. So this really bears out what we've seen from a number of studies, that although COVID-19 is an acute illness, the persistence of symptoms can be rather frequent. And I think what it highlights for us is we need to understand the mechanism. Why is it that some people, but not all, have persistent symptoms? And then perhaps most importantly, how do we evaluate someone with persistent symptoms, and how do we manage or treat people with persistent symptoms? And so then the last study I'd like to highlight in the clinical symptom or clinical manifestation portion is a study that came out of a group of investigators in Wisconsin. And what they wanted to do is distinguish risk factors and clinical outcomes for what they termed atypical versus typical COVID-19 presentations. So they did a retrospective cohort study of inpatients at 3 hospitals in the Midwest where patients were hospitalized between March and May of 2020. Now, we know most people with COVID-19 have fever and cough, but they categorized atypical symptoms as people presenting with other manifestations of COVID-19, but no fever and no cough during or within 2 weeks before the hospitalization. And what they wanted to figure out is what were those, who were the type of people who had atypical manifestations, and what were their clinical outcomes. So here are the predictors and clinical outcomes of what they're terming atypical COVID-19 among patients requiring hospitalization. So if you just look at the top of this table, 39 individuals had atypical presentations, and 124 individuals hospitalized during the same time period had typical manifestations. So fully 1/4 of the people who were hospitalized had atypical symptoms. So this was not uncommon. This was a really important group of individuals. And what was different about people who had atypical symptoms? The 2 things that really stood out to me is that the people who had atypical symptoms were substantially older than the people who had typical symptoms. The mean age of people with atypical symptoms was 72 years of age. And this is fully 15 years older than people who had more typical symptoms. The other really important finding is that in a multivariate analysis, being a resident of a long-term care facility was associated with having atypical symptoms. And that's really important because these are amongst the most vulnerable populations when it comes to COVID-19. And then the last point I'd like to make from this particular slide is when they looked at clinical outcomes, patients with atypical symptoms, atypical presentations, were 3 times more likely to die compared to those who had typical symptoms. The rate of mortality was 31% versus 13%. And in part, that was because of the people presenting with atypical symptoms were more likely to have advanced age, have multiple comorbidities. They presented more frequently with respiratory failure, and in some instances, they declined more aggressive measures. Okay, so now we're going to shift our attention slightly from SARS-CoV-2 to detection of non-SARS-CoV-2 viruses during the COVID-19 pandemic. And we're going to start from a study from Emory University. And this particular study, the background here is they noticed that among symptomatic patients or symptomatic persons who were under investigation, so-called PUIs for COVID-19, only about 16%, 1 in 6, ultimately were diagnosed as having a positive SARS-CoV-2 PCR. And so they asked the question, was this relatively low rate of SARS-CoV-2 positivity because the PCR was missing cases, or was it because these individuals who had a compatible clinical syndrome had an alternative respiratory pathogen? And so the way they did this was using a very advanced technique called metagenomic next-generation sequencing. And what this does is it comprehensively analyzes both host but also microbial genetic material. And this very sensitive technique can detect SARS-CoV-2, of course, but can also detect a really wide variety of other RNA viruses in a single sample. So they had 75 individuals who were persons under investigation for COVID-19. And they subjected samples from these 75 individuals to both clinical testing as well as this metagenomic next-generation sequencing. So what did they find? So let's start out with the people who were negative on SARS-CoV-2. There were 30 people who had a compatible clinical syndrome, but whose RT-PCR was negative for SARS-CoV-2. They then did standard routine clinical testing on these samples for other respiratory viruses. And in 27% of these people who were negative for COVID-19, for SARS-CoV-2, they found an alternative explanation using routine clinical testing, things like RSV and other respiratory pathogens. When they used the even more sensitive metagenomic sequencing, they found that 40% of people had respiratory viruses detected by metagenomic sequencing. And when they looked at the difference, the people who had a positive, very sensitive test on metagenomic sequencing, but wasn't detected on a routine clinical testing, they found 4 such individuals, and in some instances it was due to viruses such as seasonal coronaviruses, human metapneumoviruses, and in some instances it was due to RSV. So what's the take-home lesson from this particular part of their study? 40% of the time, if they had a compatible clinical syndrome, negative SARS-CoV-2 test, they could find an alternative respiratory pathogen. 60% of the time, however, they could not find an alternative respiratory pathogen. So either there was some unknown infection, the timing may have been such that the viral infection had resolved, or maybe there was a non-infectious cause for these individuals' presentation. Now let's turn our attention to the 45 individuals who were being investigated who did have a positive RT-PCR. And here the reassuring message is they did not find a very high rate of co-infection using this very sensitive metagenomic next-generation sequencing. In only one individual did they find a co-infection. So what are the lessons from this particular study? The investigators proposed that using this broad-spectrum molecular testing, including clinical testing, will detect most respiratory viral infections when utilized consistently. You don't have to have this metagenomic sequencing. You can really use standard clinical testing for other respiratory viruses. But they proposed that we really need to have a standardized algorithmic testing approach as we enter the respiratory viral pathogen season that we're just about to start on. And then the last study that I'll present in this particular section is a really important study that reminds us about the importance of looking for and thinking about HIV diagnoses during the COVID-19 pandemic. So this particular study done by investigators out of University of Chicago looked at HIV testing volumes in the context of COVID-19 in Chicago, and they focused on their emergency department as well as a consortium of affiliated healthcare facilities. Now, one thing their emergency department did, which I think is really laudatory, is they implemented a fast-track area for blood draws to screen eligible patients for HIV, including those who are under evaluation for influenza-like illness. So let's start by looking at their testing volumes, and this starts from the time of the first case in Chicago over to sometime in August of 2020. So let's first zero in on the affiliated health centers. And in the affiliated health centers, there was a really substantial drop in HIV testing, somewhere between 30 to 50% drop in HIV testing during the period of the intense period of COVID-19 in Chicago. But if you look at the orange, that's HIV testing as compared to COVID-19 testing within the University of Chicago Emergency Department. And they continue to test individuals for HIV in the emergency department. And what did they find? What they found is that between January 1st, 2020 and August 17th, 2020, they did over 19,000 HIV screens, mostly in the emergency department, and they identified 9 acute HIV infections. All of these acute HIV infections were diagnosed in the emergency department after Chicago's first COVID-19 case. And when they then looked at the rate of acute HIV diagnoses in 2020, it was more than double the rate of acute HIV diagnoses in the preceding 3 years. So a rate of 14.4 per year compared to under 7 per year in the preceding 3 years. The other important lesson here is that when they looked at the people with acute HIV, 8 of those 9 individuals had a clinical presentation that mirrored the clinical presentation for COVID-19. So it's just another reminder of two really important take-homes. One is in the right clinical setting, not everything is COVID-19. We need to think of other diagnoses, including HIV. And then the other important point is that COVID-19, we know, has been disrupting medical care of all sorts, but it's having a profound effect on HIV treatment and prevention. And if we're going to really address the point of trying to end the HIV epidemic in the United States, we're going to continue to need to test and link people to care with HIV. And this is an example of a program that really highlights that. Okay, so in the last few minutes, I'm going to talk about two treatment studies. One treatment study and one prevention study. And the treatment study I'm going to talk about is a study of remdesivir versus standard of care in people with moderate COVID-19. This is a randomized open-label phase 3 study in adults who are hospitalized with moderate COVID-19. So what's moderate COVID-19? This is people who have evidence of pneumonia, lower respiratory tract infection based on imaging, but whose oxygen saturation is over 94%. They don't need oxygen. And people were randomized, about 600 people were randomized to receive 5 days of remdesivir plus standard of care, 10 days of remdesivir plus standard of care, or standard of care alone. And the primary endpoint for this particular study was a clinical status distribution based on an ordinal scale on day 11. So here are their main results. And what you can see is that the main result is that the odds ratio for better clinical status on day 11 was the 5-day remdesivir group had a greater odds of a better clinical status as compared to standard of care. Somewhat surprisingly, the 10-day group did not have the same statistically significant benefit, although there was a trend in that direction. And so that did raise some questions, and I'm happy to discuss that further in the Q&A. When they looked at clinical recovery as well as clinical worsening, this also did favor the 5-day remdesivir group over standard of care. And then when they looked at cumulative discharges as well as safety and mortality, there was also evidence for favorable results in the remdesivir groups. In terms of serious adverse events, if you look over to the table, you can see that the serious adverse events were actually relatively uncommon in all three groups, but did not seem to be any higher, perhaps even a little bit lower in the remdesivir group. And then this is a group, many of whom will recover on their own. So when you look at mortality, the rates of mortality by day 28 was low, 1 to 2% in all three groups. So now let's finish up with the last study. This is a prevention study. We know that over the last few months, there's been a lot of attention paid to hydroxychloroquine. Hydroxychloroquine for treatment in hospitalized patients, large clinical trials have shown no benefit of hydroxychloroquine. But this particular study looked at the use of this drug as post-exposure prophylaxis. There had been an earlier study of this same topic that did not show any benefit of hydroxychloroquine, but in that earlier study, many of the diagnoses of SARS-CoV-2 infection was based on syndromic definitions rather than testing, and that was a limitation of that particular study. So investigators out of the University of Washington led this really rigorous and I think very definitive study where they took people, a little over 600 people who had close contacts to someone with SARS-CoV-2 and randomized them to get hydroxychloroquine for 14 days or ascorbic acid control for 14 days. The primary endpoint here was PCR-confirmed SARS-CoV-2 infection through day 14. Who was in the study? A little over 80% were household or social contacts, and about 17% were healthcare workers who cared for people with COVID-19 without PPE. They started the study drug or control very quickly with a median of a little under 2 days from last contact from index case to the first dose. And here are their results. What you can see is that the SARS-CoV-2 incidence was really no different between the group that got hydroxychloroquine and the group that got the control. And when you look at the rate of the cumulative incidence, it was essentially about 14% in the hydroxychloroquine group and about 14% in the control group. Really no difference between the two groups. And I think this really definitive, well-done study shows us conclusively that hydroxychloroquine does not prevent acquisition or disease due to SARS-CoV-2 when administered in a post-exposure prophylaxis setting. So with that, I want to thank you all for your attention. I would be delighted to take any questions or comments. And so maybe I'll open up the chat and open it up to questions and answers. Okay, so let's start. One of the questions has to do with this issue of do other vaccines, like measles vaccines or tuberculin vaccines, have an effect in terms of boosting immunity against SARS-CoV-2? This is a really interesting question for which we don't have a definitive answer. There have been observations that in some countries where BCG is used commonly, that rates of hospitalization or serious disease appear to be lower, but it is not certain whether that is due to the BCG, other co-infections, or whether there's some other difference. For example, the population structure of the particular population. India is a good example of that, where the population structure of India is much younger than here in the United States. So I think the jury is still out as to whether those vaccination strategies are having a kind of a secondary effect on COVID-19. I think we need more studies on this, but I think the data to date is not definitive in terms of support for that. There's a question about this really exciting idea of doing daily or very frequent self-testing to try to identify people who are asymptomatic and then prevent transmission. There's been a number of modeling studies that have really suggested that this might be a way to open up congregate settings, to open up more broadly than that. I definitely think that this is a topic that needs study. I think, and I think looks very promising to me in terms of the rationale behind it. In congregate settings, I think it's particularly important. So, in a skilled nursing facility, in an area, for example, like a college, I think these are really the right settings to be looking at this. Somebody is asking about the recent preprint from the Solidarities trial. So the Solidarity trial is a very large WHO sponsored trial done in over 11,000 people around the world and in many, many countries around the world. And they looked at a variety of what they call repurposed drugs. They looked at hydroxychloroquine, they looked at lopinavir, ritonavir, they looked at beta interferon, and they looked at remdesivir. And they found that none of those purported antivirals had an effect on reducing mortality. I think most of the attention has been around remdesivir because that result is being compared to the results of the ACT study as well as the studies from the manufacturer of remdesivir. What I would say is that the ACT study, which is a randomized placebo-controlled trial, which was double-blinded, that showed its main effect of remdesivir was on time to recovery. That is, time to being able to go from having disease to the point that one can be discharged from the hospital. And the ACT-1 study, which was recently published, showed that that there was a 5-day improvement overall in the time to recovery. They saw a trend towards a mortality benefit, but it was not statistically significant in the ACT study. Fundamentally, the Solidarity study is a different design. It's looking at mortality, which, of course, at the end of the day is the most important endpoint. But they didn't have, at least in my mind, enough data on time to recovery. And in that respect, I think there still may be a beneficial role of remdesivir in terms of time to recovery, which I do think is a clinically meaningful outcome, not as definitive, of course, as mortality, but I do think is a clinically meaningful outcome and is something that I think led the FDA to recently approve remdesivir. This is a topic that is going to continue to be discussed. I'm sure I would be happy to discuss in the future. It is a really, really important topic and a really important question. Let me just scan on. So any recommendations for post-exposure prophylaxis? That is a really critical question. We don't have a good chemoprophylactic agent, a drug which we know prevents SARS-CoV-2 as we do for HIV, where we have good data for antiretrovirals as preventive. I think there is a lot of interest in some of these monoclonal antibodies. These monoclonal antibodies are being tested in a variety of different settings. They're being tested for hospitalized patients. There's some press releases that suggest that there may be a role in mild to moderate disease, that is before people are hospitalized, but they're also being tested in the post-exposure prophylaxis setting. So particularly among household contacts, which as we've discussed, there's a high rate of transmission within households. So I would definitely say that that's an area to keep your eye on in terms of post-exposure prophylaxis. Now, of course, monoclonal antibodies, one of the challenges there are those are intravenous drugs. And wouldn't it be nice to have an oral drug like oseltamivir that could prevent transmission? And there's a lot of effort being put into that, but I don't know of anything definitive yet that we have as an oral drug. So something to keep your eyes on.
Thank you, Dr. Gandhi. And thanks to listeners for joining in. As a reminder, to view the full IDWeek 2020 virtual conference coverage program on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.